We're honored to have with us a leading epidemiologist and specialist in infectious disease. You hear from him a lot on the UVA updates and our newscasts. And just so grateful for the time of Dr. Costi Sifri, who joins us from the University of Virginia. We say good morning to you, Dr. Sifri, and thanks so much again for your time. How are you this morning?
I'm doing well, Jay. Good morning, and thanks for having me.
Yeah, absolutely. So, again, as I told Dr. Mathers, I'm sure you all get a lot of these commonly asked questions, but it's great to have this kind of a format because some of the public can't tune in to the briefings that the hospital does that are so helpful, and this just gives us in a conversation that can be helpful. And I guess there of a number of things, people often wonder, Dr. Sifri, about the transmissibility. And I know this is the novel coronavirus, so I know we're learning as over these last 2 years. Can you just help us understand how is even whether it's Omicron, which we're hearing about that is more transmissible, but in general, how COVID is typically transmitted among folks in our community?
Yeah, great question and a great way to start. So there are perhaps three different ways that coronavirus, SARS-CoV-2 is the virus that causes COVID-19, can be transmitted. Two are predominant, and the third is probably very rare. And so the first is, through respiratory particles that you inhale. So it's inhalation. So you breathe it in, it goes into your airways, and starts to cause infection. The second is through droplets that are deposited on mucous membranes, like in the mouth or in the nose. And so that's the second way. That's sort of what led to the 6 feet distancing rule that we're very familiar with, that if you're farther than 6 feet away, that your chance of encountering a droplet that finds its way and drops onto a mucous membrane is very small. And then the third way is through contact, through touching a surface and then inoculating yourself by rubbing your eye, or for those of you who pick your nose, which is everybody, bringing it into your body that way. That third way is probably not zero. It probably it does occur, but it's probably very, very rare. So the primary way that coronavirus, that the COVID-19 virus is being transmitted is through these respiratory particles, whether they be aerosols, small droplets, small aerosols, or droplets.
Yeah, we're talking with Dr. Costi Sifri from the University of Virginia. In terms of Omicron, we've seen this increase in transmissibility and all these surges. Have you guys, and this may be hard to quantify, is Omicron a little more transmissible in the third type that you mentioned, touching surfaces, touching your face, that kind of thing?
Yeah, it's a great question. I think one that many people are interested in, and thus far, there's no evidence to say that it is. I think we're always concerned about that, and certainly looking at the literature to see if there's maybe some cases that are occurring through this through this touching mechanism. We call it these fomites, through this transmission through contact. And so far, there haven't been reports of an increased number of these. These are as I said, really rare. So we're attentive to it, trying to see if that's happening. But I think we know enough now, 2+ months into the Omicron surge, that we're not seeing a substantial number of those, or else I think it would have been borne out in reports.
Dr. Costi Sifri is with us, and Dr. Sifri, I would ask if you'll indulge me for a second. I forgot to ask your colleague, Amy Mathers, who specializes in this, and so I understand. But one of the common questions I get, and remember we experienced this last year, is it allergies or is it COVID, right? Everybody was just freaking out, the symptoms. And now with Omicron, that has even been accentuated. At the testing level, Dr. Mathers kind of really informed us about the RNA that can be traced and the sensitivity of a PCR test. I guess the basic question is, from what you and your colleagues are seeing, is there a very easy way to tell the difference between SARS-CoV-2 and I hate to refer to it as the common cold, but other viruses? Is it easy to distinguish?
They're by and large, unfortunately not. I think the overlap in symptoms between COVID-19 and other respiratory illnesses is significant. So, what can look like the common cold may be the common cold for some, due to SARS-CoV-2, due to COVID-19. There are some distinguishing symptoms that have been seen with COVID-19 that aren't seen at all, or at least very often, with other respiratory viruses. So those are those sort of telltale loss of sense of taste or smell symptoms that some people have. That is really uncommon with other respiratory viruses, but was sort of a calling card for COVID-19. Now, unfortunately, with Omicron, those types of symptoms are less common than they were with previous variants. So we're seeing less of that, unfortunately. So the long and short of it is, if you have a cold, you have symptoms of runny nose or sore throat, headache, maybe some low-grade temperatures, it could be COVID. And, given the amount of Omicron that there is right now, there's a good chance it could be COVID.
Would it be, and last on this line of thinking, Dr. Costi Sifri is with us, would it be safe to say that if someone has those symptoms and they match, they could be flu, could be COVID, and they take a PCR test and it comes back negative for the COVID vaccine, not the vaccine, but the COVID protein, it would be fair to assume that you just have the other disease? Would that be fair?
That is probably fair. So there's a couple things to that. So like any test, there can be problems with how the test is collected. So did the nasal swab get into the right place and get enough cells? Was it collected in the right manner? And so there can be those types of processing issues. And then was it run correctly in the laboratory? But, by and large, I think those are uncommon when they're performed well, which is, I think, the case in most situations. If you take a look at testing at our, around our community, either here at UVA Health or in other locations. So I think that since there are other respiratory viruses that are occurring, I think you can probably be pretty comfortable knowing that it's not COVID. Now, that being said, if you had also at the same time a clear exposure to COVID, then maybe you should be a little bit more cautious and act as if you have COVID. And if it was a true clear exposure and you're not vaccinated, that's a really concerning scenario. And so in those situations, the guidance would be you should be quarantined anyway if you're not vaccinated. And then the second thing is like, right now we should all be wearing masks and being attentive to the things that we're doing and potentially putting other people at risk. So even if you test negative, it really behooves you to wear a well-fitted mask to make sure that you're not exposing people to COVID. And truthfully, you're also, if you're doing that, also not exposing them to whatever germ you're happening to be carrying that's causing you to feel sick.
Yeah, Dr. Costi Sifri, in our last few minutes, really appreciate his time. You mentioned masks, Dr. Sifri, and obviously in our country, not just our communities, there is unfortunately just a lot of discourse and conjecture around it, and sometimes even with, folks will point to different studies about what is effective and what is not. Without going into all of that, I guess one of the questions that I would have is asymptomatic transmission of the virus among vaccinated people. Is that something we should be concerned about? Or is it, if the individuals are vaccinated? I remember we were talking about this last summer. Should we be less worried about asymptomatic transmission if you are fully vaccinated and boosted?
It's a great question, and it is a difficult thing to summarize in a short period of time. But it is different now with Omicron than it was last summer when we were on the heels of the Alpha variant and we're starting to see the Delta variant. Last summer, if you're vaccinated, you are not likely to be a carrier of COVID and much, much less likely to be able to transmit it even if you were a carrier. And Omicron is different. Omicron has this ability to evade our antibody responses early. It causes a high viral load early in the course of illness. And so there can be, carriage of the virus, early, after exposure. And even if you're vaccinated, you potentially could be a source and transmit it to others. And I think that's what we're seeing. We're seeing a lot of, what are called breakthrough infections. And so that was a difference that's occurred with Omicron and probably speaks to the importance of masking, even for those who are fully vaccinated, and now fully vaccinated means boosted, at times when there is a lot of community transmission of COVID.
Yeah, Dr. Costi Sifri, thank you so much again for your time. Sometimes listeners will reach out because, you and I were talking about this a little bit, parents and kids and everybody's, the FDA is reviewing potential vaccination for 6 months olds and up, and we don't have time to get into all of that. But these quarantine periods can challenge certain parents because of their schedule, right? We all understand that. The daycare center says we're going to be we're closed for 10 days. We have a COVID exposure, and it's hard. I guess what I would ask you, Dr. Sifri, is in terms of our smaller children, which we, of course, their susceptibility and is there been any new research in terms of how susceptible they are to, say, Omicron as a variant, and if they need the same type of quarantine periods? If adults are 5 days, do they tend to line up, or is there still too much that we need to learn about that?
This is still a learning process, and to boil it down, what we do know is that kids are susceptible to COVID and including Omicron. We are seeing, a fair amount of Omicron in school-age children right now. It's also important to note, you touched on vaccines. It's important to note that vaccines are effective for kids age 5 years of age and older. And as you alluded to, the FDA may be reviewing data very soon regarding vaccinations in younger children. That's going to be another conversation. But we have the tools to prevent transmission of COVID between children. And we also know, just in general, I think this is true both for kids and for adults, the period of infectiousness is highest early during the course of illness. And it's kind of like the flu. Sometimes your period of transmissibility of COVID is higher before you develop symptoms, even before then, and then once you develop symptoms. So that's what led to the CDC to sort of recalculate this period of quarantine for the sort of early for the first 5 days of illness, understanding that that's the highest period of transmissibility. The challenge, I think, that schools face, and sometimes other places that have a lot of people in a small space have, is that that you're in a congregate area where there's potential opportunities for transmission that can occur that maybe extend that where those less common times of transmission, sort of 5 days after initial diagnosis, that those may be important. And so that's led to this sort of patchwork of isolation timing recommendations that I think are confusing for the public. So this is a really, really challenging area, and probably in what I try to instruct people is it's a matter of risk reduction. We need to understand that elimination of all harm or all potential exposure is really, really difficult, and what the CDC has provided is sort of guideposts to try to reduce the periods of transmission risk that are greatest, to really focus on those areas, but to understand the best opportunities in terms of places where that can be implemented.
Yeah, Dr. Costi Sifri has been so gracious with his time as an epidemiologist at the UVA Medical Center. Consensus, I was talking with one of your colleagues in a different department a couple of weeks ago, and when we've ever tried to tackle infectious disease or disorders, finding medical consensus is not easy, but once we found it, the efficacy, I think, naturally went up. Are you seeing consensus in this research around COVID-19, Dr. Sifri?
This is that's a very good question. I think very insightful. And I think one of the differences here versus maybe some other areas of medicine is, how rapidly things are changing. So, this virus is evolving as we're evolving in terms of our ways that we combat it, the way that we manage it. 2 years ago, this was essentially a bat virus that spilled over into the human populations, and it was acting like a bat virus. And now 2 years into this, it's gone through some evolution. It's becoming more of a human virus. And because it's evolved, we need to adapt to how we respond to it. And that can lead to differences of studies and differences in efficacy of different interventions that have those differences reflected in different times. So that evolution is a little bit challenging for people to deal with. Now, that being said, we've gone through this before, and I bring people back to the pandemic influenza virus of 2009, 2010, the H1N1 virus, when that hopped into humans. So as an example, then we had a recommendation that people should be isolated for 10 days after they had the flu virus. But that evolved, and once we got to know the virus better and saw what its impact was, to say, you know what, you don't need to isolate, after you have, your symptoms have gone away and you no longer have a fever and you're not taking Tylenol or other medicines to mask a fever. If you meet those benchmarks, you can, go back to school, you can go back to work, and we sort of learned more about that. And I think that's sort of the same type of process that we're in right now. We're learning more about the virus and understanding what's safe.
Yeah. All right, Dr. Sifri, I appreciate it. And we have about 30 seconds left, but when you and your colleagues are saying your recommendations, you advise the University of Virginia, obviously, I hate to ask a question like this, but I think it beckons. I mean, you all, despite what everybody else is maybe saying or disagreeing or however it works, I would imagine as doctors, you see this every day. You just want this thing or find a way to get to the end. And do you have some hope that we're getting closer?
Very much so. I think sort of what I was alluding to, saying that this was a bat virus 2 years ago and now it's become a human virus. We are at a much different place here than we were 2 years ago. We have an incredibly robust way of detecting the virus through great diagnostic tests. We have really still very impressive, very effective vaccines. We were in some ways the benefit of just incredibly effective vaccines initially, and they after 2 years of work through this, they still remain remarkably effective in the important measures that they're made for, and that's to prevent hospitalization and death. And we now have really, really good therapeutics. We don't have enough of them now, but that's going to change in a matter of months. So I think we have the tools that we need to combat this virus, and I think the challenge is getting through this Omicron wave and then seeing what comes afterwards. We need to remain vigilant that new things can crop up, but the tools in our toolbox now are extensive, and I think that we're in a much better place now than we were even 6 months ago.
Wow. So grateful for your insight and the time you gave us, Dr. Sifri. Really appreciate the work you're doing over at the University of Virginia. So thank you so much for giving us this extended time and helpful information for our community. We're really grateful.
Thank you very much, Jay. It's great to be with you.
You too. Take care, sir. That is Dr. Costi Sifri, leading epidemiologist and part of a great team over there at the University of Virginia with Reed Adams and Tyson Bell and others and Dr. Bill Petrie. It's just a great team over at UVA.